Dr. Kama Dikshit, Dr. K.N. Arya, and Dr. Rajkumar Verma. Okay. I request Dr. Vivek Mangla on the stage and request Dr. R. Dhananjay Saxena to speak something about our legendary speaker. Thank you so much.
License. I welcome Dr. Vivek Mangla. He is a highly accomplished surgical gastroenterologist and GI oncologist with over 22 years of experience. He currently serves as the Senior Director and Head of GI and Hepatobiliary Surgical Oncology at Max Super Specialty Hospital, Vaishali and Patpargan. He is a super specialist surgeon who primarily treats complex abdominal cancers and diseases using advanced minimally invasive and robotic techniques. So, welcome Dr. Mangla.
Thank you Dr. Dhananjay for a kind introduction, and I must thank Dr. Bundela and congratulate him for this wonderful meeting. And as regards Vikas Singla and Vivek Mangla is concerned, I think we worked long years together, All India Institute, then Gangaram Hospital. And so what was said was Vivek Mangla and Vikas Singla. So I've heard so many patients looking for Vivek Singla and Vikas Mangla. So it happens all the time. So coming down to a topic which is a disease which is relatively less common seen, especially when we talk about hilar cholangiocarcinomas. These are relatively uncommon malignancies comprising of a very small proportion of all the GI cancers that we treat. They could be intrahepatic when the mass is entirely in the liver with very little or involvement of peripheral bile ducts. Or it could be a tumor which is arising from the hilum, that is where the right and the left hepatic ducts join. And then third, the site would be mid-CBD cholangiocarcinomas which are affecting the mid part of the bile duct. And then the fourth, arrow is not seen. So, and the fourth ones would be involving the distal part of the bile duct just above the ampulla. Now, why the location matters? The location matters simply because when we talk about the distal bile duct tumor, it is going to be treated by our periampullary cancers or tumors affecting the last 2 centimeters of the, so tumors arising from any distance within 2 centimeters from the ampulla. The anatomic organs in that area change, the nature of surgery changes, the nature of vessels in that area changes, and that is why it is important to have the location. When we talk about intrahepatic cholangiocarcinoma, intrahepatic bile duct tumors, they would be treated for any other liver tumor, for example, HCC, except for the fact that you wouldn't see as much of chronic liver disease in these patients. The most complex and challenging would be tumors which are arising at the hilum. Now, liver hilum is an area where you have the common bile duct being joined by the cystic duct, and above that the common hepatic ducts dividing into right and the left hepatic duct. And then the right-sided secondary confluence, that is the right anterior and posterior ducts coming and joining there. This is also a very important area where the port vein bifurcation would be there. The main port vein would be dividing into its right and left branch. And the right hepatic artery would always either cross behind the bile duct or in front of the bile duct in most of the patients, leading to frequent involvement of right hepatic artery in these patients. Now when we talk about management of these patients, I think surgery is a part of it, it's an important part of it, but very important as to how we prepare these patients and how we have to evaluate these patients. Most commonly these patients will come present with obstructive jaundice, we all know, itching, clay-colored stools, dark urine, sometimes they'll have vague abdominal pain, weight loss. Now one thing important that we have to understand and differentiate is the fact that quite often the jaundice in these patients would be a painless progressive jaundice. Now, when we compare it to somebody with a stone disease, which is the second common differential, which leads to slightly different evaluation pathway, is that if a patient who is 50, 55, 60 years old and presents with painless progressive jaundice, this patient is likely to have a periampullary cancer or a bile duct cancer, which could be in hilar or a distal bile duct cancer. That is an important point, and why is it important? I am going to allude to you next. And obviously when you examine these patients, you will find some jaundice, scratch marks. The gallbladder being palpable in the patient who has not had cholecystectomy would tell us that most likely the biliary block is distal to the cystic duct and CBD confluence, leading to the possibility of a distal cholangiocarcinoma being more common. If we are not able to palpate the gallbladder, we may not be able to palpate the gallbladder for multiple reasons, even when it is distended, but that is one clinical sign which could help you differentiate to some extent whether it's a distal tumor or a proximal tumor. Tumor markers CA and CA99 both have their values. The important thing is in indeterminate strictures. For example, you've got a 65-year-old male patient who's come with a stricture in the distal bile duct, mid-CBD. We don't have a diagnosis. A normal CEA or a normal CA99 does not rule out the presence of malignancy. This is extremely important to understand. This is one side of the story. The other side of the story is that if got an elevated CA19-9 in a patient with obstructive jaundice, it may not actually be related to a tumor. Any benign disease which leads to obstructive jaundice or biliary obstruction can also lead to false positive CA19-9 elevations. So two things I said, CA19-9 can be negative even in the presence of tumor, and a positive CA19-9 does not mean that there is underlying malignancy. So what is important is these two markers we should ideally do when we have kind of confirmed the presence of a malignancy, or we are strongly suspecting the presence of malignancy. We are not trying to rule out or rule in malignancy with these tumor markers. The next evaluation, I think if anybody's noticed, I went from physical examination to CT scan. Why is not an ultrasound there? Important modality? Yes, ultrasound should be there. It is missing in these slides. Ultrasound is going to tell you a few things in these patients. It may tell you if there are metastases, it may tell you if there is ascites, if some of the other differential diagnoses. Most importantly, you have to see that the CT scan precedes the MRCP. When you've got a patient who presents with a painless progressive jaundice, a CT scan is going to be more important a different evaluation modality, because it is going to tell you a lot of things. For example, if there is a tumor, it will show you the tumor. It will tell you exactly where the biliary obstruction is. It will tell you the extent of biliary involvement as well. Additionally, compared to an MRCP, it will tell you the vascular involvement, whether the right artery, what's happening to the right artery, its anatomy, as well as whether it's involved or not. It will also tell you, you can also do volumetry, which is going to decide what surgery is going to be done, and actually that is going to decide the next steps as well. And obviously the liver, peritoneal and non-regional nodal mets would also be picked up better on a CT scan. MRCP can help delineate the biliary anatomy to some extent and biliary involvement to some extent, but generally what happens is, especially in a patient who's had obstruction for some time, there will be a lot of sludge which would tend to overstage the disease, and it may be really, one may end up overstaging the disease rather than accurately staging the disease. Some kind of imaging, some kind of cross-sectional imaging should be done before any kind of biliary drainage or any intervention in these patients, and this is something which I would like to tell to my gastroenterology colleagues and generally anybody sitting in the audience. Unless you are really pushed to the wall, you have a patient who is sinking down, significant hypotension, high inotropes, very significant comorbidities, deranged renal functions, you got Raynaud's pentad, you got an encephalopathy thrown in. These are situations wherein we could do the preoperative biliary drainage directly. Otherwise, it is extremely important to first, in a patient with obstructive jaundice, to do some kind of a cross-sectional imaging. You have a patient who is a middle-aged female, had gallstones for donkey years, you done an ultrasound, shows a dilated CBD, she had pain. You are perfectly fine in doing the ERCP directly. There are a lot of predictors there for a CBD stone. But in a patient, especially if the patient is elderly and the patient is obstructive jaundice, which is painless, it is important to do a cross-sectional imaging before doing any further intervention or preoperative biliary drainage or any kind of biliary drainage for that matter. PET-CT becomes important in some patients, but we have to understand that it's got a very limited role and its routine usage not generally recommended by any guidelines in the world. This is what I tell my patients as well when they sit across in my OPD and ask this question. I said, you need a PET scan, you get it done, I don't need one. If you want, I'll advise. As far as I am concerned, you don't need a PET scan, but if you want a prescription for a PET scan, rather than go to somebody else and get it written, we'll write it. Nobody across the world does as many PET scans as we do in India, and this is a fact. And most of them are quite often unindicated. Invasive cholangiogram generally would be a part of a preoperative biliary drainage. You would generally not do a diagnostic cholangiogram in these patients. And when there is a doubt in diagnosis or you need palliative neoadjuvant therapy, you can consider brushings, you can do cholangioscopy. I think Dr. Puri showed some cholangioscopy images for stone disease. It works equally well for indeterminate biliary strictures, and you could consider cholangioscopy there as well. ICG retention at 15 minutes is an important marker for liver function, and IgG4 could be a possible differential diagnosis of autoimmune cholangitis and may help rule out in some patients in whom the clinical presentation is not characteristic. In earlier times, we used to do a lot of this bismuth correlate classification, but there were a lot of issues with it, and that's why we now do a TNM staging, which I'm going to allude next. Diagnostic lab has some importance. It should always be done in any patient in whom we are considering portal vein embolization for liver augmentation or prior to any major surgery which is being planned for these patients. Now, as I said, the location for the three sites, intrahepatic, the hilar and the distal bile. Now, these three are three different fruits, vegetables, whatever you want to call it. They are treated absolutely differently, they are staged absolutely differently. When we talk about tumors in the distal bile duct, they would be staged more like periampullary cancers. You are looking at the depth of bile duct involvement or involvement of the adjacent pancreas or the duodenum. When we come down to hilar cholangiocarcinomas, I believe this is intrahepatic bile duct tumors. They would largely be staged based on their size and major vascular involvement, which would be almost quite similar to how you would stage the hepatocellular cancers in the TNM staging. And this is what is going to be a large part of my talk subsequently, is the hilar cholangiocarcinoma, tumors which are rising closely related to the primary hilum, wherein involvement of one side of the bile duct, the other side of the artery, the one side portal vein, the other side bile duct, and lot of these combinations, permutations can exist which can change the surgical plan but also the drainage plan as well. So it comes down to preoperative preparation of these patients. A statistic I would like to share is that in high volume centers abroad, mainly in Japan and as well as in Korea, 85 to 90% of hilar cholangiocarcinomas are operable and they get surgery done. In our country, when we have looked at our own data, we see so many slips happening all the time and at various levels, and I'm going to show you some of them, how they happen. And this is one disease in which to be prepared is half the victory, is one side of the story, but very important is once we prepared, we do not prepare well and we fail in our preparation. Who fails? The patient fails, the family suffers. These are situations where we have seen a resectable disease becoming unresectable. You had an indeterminate stricture in a patient, diagnostic evaluation upon diagnostic evaluation upon diagnostic evaluation, and by the time you've really been able to give up on the diagnostic evaluation and thought that maybe this is likely to be a malignancy, or even if it's not a malignancy, needs surgery, by that time you start seeing liver metastasis in these patients, and that is quite a disastrous situation. So in an elderly patient with an indeterminate stricture, malignancy is a very, very important differential diagnosis, and a plan should be made for these patients. We've had patients in whom there's a hilar block, somebody attempted an endoscopic stent placement, and the patient had severe acute pancreatitis and died in that episode of severe acute pancreatitis. Third important challenge that we see is that, as I talked about, and I'm going to allude you subsequently also, very important, which part of the liver is going to be saved at surgery. Now, if you drain endoscopically or by percutaneous technique, whatever you do, the other side, the patient is going to need a drainage for the other side subsequently also. And that is why it is extremely important to do a cross-sectional imaging, discuss with the surgical team. Unless pushed to the wall, you decide on which side you are going to drain, be it endoscopically or be it percutaneous. We've had patients in whom a covered SEMS has been placed in potentially resectable disease in a hilar setting, and the patient had unremitting cholangitis. We've had accidental portal vein embolizations of the FLRs. We've had a non-FLR side PTBD, and this patient came to us from abroad, in whom actually what had happened was, the patient always needed an extended right resection. The right-sided bile duct was drained, the left side was never drained, and finally when it came down to somewhere around surgery, the treating team realized that all the time the left side has become even further small, and that's when the patient came to us. We tried to drain the liver, we tried portal vein embolization then, but it didn't work, and we were never able to get this patient's FLR to be of the adequate size. Extremely important to prepare these patients well. Nutrition and hydration are extremely important, and then in today's times with increasing coronary disease, diabetes and renal issues, optimization for comorbid illnesses is important. Why do we need preoperative biliary drainage? We need preoperative biliary drainage selectively, very, very selectively in patients with distal bile duct cancers. I'm going to tell the indications next. But in hilar cholangiocarcinoma, since we are going to remove a significant part of the liver, it is extremely important to drain the liver of the future liver remnant, so that when we take out the liver, this part of liver has to be growing well for this patient to survive the surgery and recover. If you do not do a preoperative biliary drainage and operate at very high bilirubin, say 10, 12, 15, and you're doing a major liver resection, you are going to have high risk of postoperative liver dysfunction, increased intraoperative blood loss, and then what happens is you decompress the side which you're going to save, the hepatocytes recover, the liver function improves, the atrophy which is happening in these patients on the FLR side starts stopping. There are a lot of disadvantages of routine preoperative biliary drainage. So a patient with a distal bile duct cancer only selectively will need preoperative biliary drainage. And why and when selectively? When the patient has cholangitis, is having fever, jaundice, there is need for neoadjuvant therapy. The patient has unresectable disease, Given the expected delay in surgery in India, that's not very uncommon. You will have a patient just waiting for a date in the government sector. We worked at All India Institute. We wouldn't be able to operate a patient before a month, by which time his bilirubin would go from 6 to 20. And that's one situation where you could consider stenting. But then, when you stent these patients, you have to understand that there is certain procedure-related morbidity. There is definitely a delay in definitive surgery. There is very clear evidence which suggests that you should not ideally operate these patients less than 14 days after the stenting has been done. It leads to increased morbidity, as well as there is some evidence for mortality as well. There's a Dutch trial which clearly shows that there is marked increase in infectious complication. In our own experience, a stented Whipple's bile never comes to light. It will always show organisms, it is contaminated, and these are the patients who will have a high incidence of wound infections, as well as need for higher antibiotics to get them home. It just because of that increases the cost and hospital stay, and then in some patients who develop pancreatitis from the ERCP, the surgery also tends to become a little more difficult. So we will need a preoperative biliary drainage for hilar cholangiocarcinomas in practically most patients that we see today. Occasionally we'll have a patient, it could be done endoscopically, or you can do a percutaneous biliary drainage. Our preference to some extent has been a PTBD, although what we've seen is it is all operator dependent. You've got a good endoscopist doing good ERCP stenting, and there has been some discussion on the plan of the side which is to be stented. It works equally well, and there is Japanese data which talks about ENPD all the time. Percutaneous biliary drainage helps. It is more accurate. You are sure which side the stent is going, the tube is going, because that's the side they are going to puncture. You also get a direct cholangiogram as well. External drainage is the issue, and you tend to lose some fluids and electrolytes there. For a hilar cholangiocarcinoma resection, where you are going to do a major liver resection, you would like the bilirubin to come less than 5 mg%. And the targets, most importantly, quite often the indication is cholangitis, and you just wait for the duration that cholangitis to settle. The bilirubin comes down to normal. In a hilar cholangiocarcinoma, you really, if a PTBD has been done, you don't really need to wait 14 days, because there is no chance of pancreatitis happening in these patients. And then, generally speaking, some centers would say 5. In our experience, we've usually believed the Korean data which talks about having a bilirubin less than 3 for the best post-operative outcomes. You have to try and get the bilirubin down. Normalization shouldn't be the aim, because the disease is, there's a ticking time bomb of the disease increasing in its extent all the while, and it will take some time, especially if the patient has liver dysfunction. It may take a little longer. And if you've got a patient who's got cholangitis, you'll have to treat the cholangitis, and all this while, if you're waiting, your tubes start getting clogged, they start getting killed, and there tends to be a disease progression. When we talk about resectability, the extent of tumor in the bile ducts, whether the main hilum is involved or the disease extends intrahepatically into the right side or the left side, the degree of vascular invasion, the right artery, the hepatic artery proper involvement, main portal vein involvement, and sometimes in these patients, when the obstruction has been there for a period of time, what you will see is that there is a lot of atrophy which will happen to the side in which there has been a biliary obstruction for a period of time. And you need at least 30-40% liver remnant to have this patient going home well after surgery, and then metastatic disease has to be ruled out. Very important to rule out resectability and unresectability, and this is very important to do well before the first intervention, because when you do it before the first intervention, you do the first intervention right and in one go. If the disease is resectable, the patient may need preoperative preparation, and then you need to do volumetry and everything else. Now, most important thing is, when do we say it is clearly unresectable? So you have a patient, say for example, is 85-90 year olds, multiple comorbidities, on dialysis or on the verge of dialysis. You know that this patient is going to be very difficult to get to surgery. These patients are medically unfit for surgery. You've got a patient who's got cirrhosis or portal hypertension. These patients would generally not be candidates for a major liver resection. When we talk about local tumor extension, bilateral involvement or involvement of one side bile duct with anything happening to the other side, the artery, the portal vein, or there being atrophy on the other side, because that side you are not going to be able to increase in size whatever you do. These will make these tumors operable. Main portal vein, short segment involvement occlusion encasement, you can actually resect with these tumors, and if there is atrophy on the other side, you obviously cannot operate on these patients. The future liver remnant, or the part of the liver which is going to remain in the patient, is the entire crux of this talk as well as the management of these patients, and it is towards this safeguarding this part of the liver which is going to remain in the patient. You need at least 30% with a normal liver. If you've got a diseased liver, there is some ongoing chronic hepatitis, it could be metabolic steatotic, or if there is cirrhosis, then by and large patients wouldn't be candidates for major liver resection. If the liver remnant is small, we can do a portal vein embolization. Liver has got a remarkable capacity to regenerate. So you block the right-sided portal vein, the left-sided portal flow will increase, and the liver will start increasing in size. and with that there is improvement in function on the left side as well. So port vein embolization remains the most common way of doing it. You would need it whenever there is an inadequate FLR. You would generally need 2 to 6 weeks time for the liver to grow enough for you to operate upon these patients. Coming down to surgery, the goal is complete removal of the tumor and doing a regional lymph node clearance. Mid-bile duct cancers, occasionally you will have a patient with a very small tumor wherein you could get away with just a CBD excision, but then more often you will have a right artery involvement or the tumor extending towards the distal bile duct wherein you will have to go ahead and do a pancreatic duodenectomy. In a distal bile duct cancer, pancreatic duodenectomy and pyloric preservation when feasible. So this is a picture of a Whipple's, this is a picture of a pylorus preservation. In our experience, what we've seen is after the initial few days, pylorus preserving or preserving the entire stomach, it leads to a lot of post-operative nutritional benefits in terms of their weight gain, in terms of their vitamin, iron deficiencies, calcium deficiencies. These tend to happen less when you try to do a pyloric preservation compared to a classical Whipple. And that is why in our present series, majority of the time, I would say 95% of the time, we would do a pyloric preservation. And for bile duct cancers, generally there is no duodenal involvement. You would almost always end up doing a pylorus preservation. Coming to hilar cholangiocarcinomas, these will need major liver resections. Extended right or an extended left hepatectomy. Caudate has to be removed to ensure R0 resection. The extrahepatic biliary tree has to be removed. The biliary reconstruction will be with the hepaticojejunostomy. Regional lymphectomy has to be done. If there is scope for further resection or trying to extend the margin, you should do a frozen section of the margins, and then quite often these patients will need vascular resection, sometimes a sleeve, sometimes a segment of the portal. These are some of the diagrams of the bile duct wherein we would divide the bile duct and the liver for getting the part of the liver to be removed. Two cases I'm going to show you next. 59-year-old gentleman who had some element of chronic liver disease, but we were able to do PTBD, got some hypertrophy which was not adequate, then we waited longer, and then we had adequate hypertrophy, and then we were able to do a resection. There was some ascites post-operatively and the patient completely recovered. There were few lymph nodes involved. The patient received adjuvant chemotherapy. Second case was another gentleman, left-sided cholangiocarcinoma. The first one was a right-sided tumor. There you can see the atrophy of the left side, bile duct dilatation. So when there is this kind of an image, it is good for the surgeon because then you don't need a port vein embolization. The right side anyways is larger than the right posterior sector is always larger than the left lateral segment unless there is vascular involvement. And so in this patient we could just get away with PTBD and then direct surgery. And then this patient underwent an extended left hepatectomy with a caudate excision, with CBD excision, as I said, would be part of every surgery and with an uneventful recovery and discharge. And these are some of the large data from Japan, and then this is again a Japanese data, 574 consecutive resections. And you read these papers, you realize that what we end up doing is we end up resecting a lot less than what we could. And this is the Asan experience. With 5-year survival, post-resection and chemotherapy for bile duct cancers tends to be still not that great. But when we compare it to a situation wherein when you are not able to operate, why resection matters and why there is need for careful preoperative planning. Because the moment you are putting an uncovered SEMS in a hilar cholangiocarcinoma, we know that this patient's chance at being alive at 1 year is less than 5%. So you've kind of put a reverse clock ticking on this patient the moment you've labeled this patient unresectable. So when we talk about unresectability, there has to be a very good discussion, a good team. I have had patients in whom, there was a recent patient who came to us from some place in Punjab wherein the local surgeon had deemed the disease unresectable. They put in a metal stent, and that was an uncovered metal stent. And we had a lot of trepidation, but then we realized the disease was operable. We resected the tumor, we removed whatever little bit of metal stent we could remove from the intrahepatic bile duct, and then did hepaticojejunostomy. The patient did well. Obviously, when you try doing these patients in such kind of patients in whom the initial management hasn't been proper, you obviously do not get that kind of results. These patients will have morbidity. These patients will stay longer in the ward. They'll have some liver dysfunction which will take time to settle down. So it's extremely important to have multidisciplinary team taking care of these patients from the initial beginning. When you see this patient, you do a CT scan. A proper good quality triphasic CT has to be done for these patients, provided the renal functions are normal. It needs a good assessment. Your local surgeon is not being able to assess. He's able to assess, fine. Not able to assess, you can discuss this patient with anybody. And then SEMS, if putting in a distal bile duct cancer, it has to be covered. And in a hilar cholangiocarcinoma, it is being uncovered stent, but only if malignancy has been proven. You have a patient in whom, God forbid, this is a final benign diagnosis. That uncovered stent to get out, be it endoscopically or surgery, is hell of a job. and these patients will keep surviving and be troubled by their stents. Extremely important. So to summarize, bile duct cancer, the location matters a lot. There is a high chance of resectability in these patients, but it needs very careful preoperative evaluation and preparation. I call it a very deft planning and a clockwork precision execution of that treatment plan that has been made, and multidisciplinary team management ensures better outcomes. Thank you very much. That's my team from Max Vishali.
Thanks, Dr. Vivek Mangla, sir, for delivering such a wonderful talk, and the chairpersons, if any inquiry, please just go ahead.
It is a great job, Dr. Mangla, to deal inoperable most of the time. This is your insight is very nice, and I think it is a very good lecture for all the surgeons. Thank you.
Yeah, can I make a comment? Yeah. So Vivek, so what at our center at Max, what we do? So if there is a suspicion of malignancy with ampullary, pancreatic, hilar, immediately we inform our GI oncosurgeon, we inform our medical oncologist. We all sit together and make a plan whether this patient requires upfront surgery, preoperative drainage. That decision has to be taken in consultation with your other colleague. That's mandatory. Message is very clear. Please don't fiddle with the bile duct in a patient with suspected biliary malignancy. You may do more harm. More often than not, the patient doesn't require preoperative drainage. And regarding the workup of jaundice, any patient with the jaundice, you are very right, ultrasound should be the next modality. If based on the clinical finding and ultrasound finding, we are suspecting a stone, go ahead with the either MRCP or endoscopic ultrasound followed by ERCP. Suspicion of malignancy, go with the CT angio. The plan is very clear. Jaundice, do ultrasound.
I think what Dr. Vikas is saying and I have said is extremely important for everybody sitting in this audience. We need to see our patients a little more clinically. A painless progressive jaundice, after an ultrasound, the CT scan is the investigation. You suspect stone disease,
yes.
You can do an EUS as Dr. Vikas says, you can do an MRCP.
Even with the stone, we want to confirm stone. If there is a suspicion of stone on ultrasound, many times ultrasound can be fallacious. We will do either MRCP at our center. I will definitely do endoscopic ultrasound.
So, I think this is what is not going to be the practice far and wide.
So there should be very high probability of stone. That there is a high bilirubin, cholangitis. If borderline LFT elevation, please confirm stone. If you are doing ERCP in the absence of stone, it will lead to pancreatitis. You will agree with that. As an endoscopist, we are worried about pancreatitis. So we first will confirm the stone in the bile duct, only then we will take the bile duct.
Absolutely agreed. And so that is why me and Dr. Vikas, we were comrade in arms, AIDS and then Gandhara, but we were like a very good. Brachytherapy is coming up in some way in unresectable bile duct cancers, wherein people have put PTBD tracks and then put radiotherapy catheters and given RT. For a small intrahepatic bile duct tumor in a patient who's unfortunately got cirrhosis as well, that's not a common occurring. There you could use some form of ablation, be it RFA, be it microwave, or you could even give SPRT.
Can I make a comment on that?
Absolutely.
So when we do RFA, it can be done by the US guided needle-based catheter. So if we have cholangiocarcinoma unresectable, so we can do RFA first, followed by the metal stent placement. That is for the unresectable cancer. This patient will never be fit for surgery. So we do ERCP guided RFA ablation of the tumor, then we place the stent. That can increase the stent patency time. And regarding the pancreatic cancer which are unresectable, surgeons say that it cannot be operated. Now there is rule that if you do the US needle guided RFA, that will lead to necrosis of the tumor, and that necrosis will lead to inflammation and the immune response against the necrosed cell. And that has shown to increase the survival, but it is still in the experimental stage. So I think in the future there is definite role of RFA combined with the immunotherapy. For hilar cholangio, it will increase the patency of the stent.
So in hilar cholangiocarcinoma, one point that is Dr. Vikas has very valuably raised is the fact that quite often we are not able to treat these patients with systemic therapy because of the stent blocks and cholangitis.
Yes.
So if we are able to delay the stent blocks by whatever we do, be it RFA done through EUS needle or ERCP guided or a PTBD tract and radiotherapy, these help these patients to get their systemic therapy, because sometimes you will have some decent survivals on that. But the biggest challenge is in achieving that. That's what kills a lot of these patients actually.
Don't rush for ERCP in a patient with biliary obstruction. The message is, please take this message.
That's great insight, both of you.
Many congratulations. Everything else has
Things
to be
all improve.
Yeah, and everything has to facilitate that. You have to get this patient to surgery.
Either use RFA or some chemo radio. These are the accessories. But main thing is the resection, I think. Thank you.
Thanks, Dr. Thank you, Dr. Satish Sharma to kindly do honor to our respective moderators as well as the chairpersons. I request to do honor to Dr. UK Jain sir first of all. Okay. Arya sir. Dr. Mavarma sir. Good evening.
Okay, look at here.